if you could go back to your first year and like back in like 1935, what? So it feels weird like carrying a backpack and walking on campus.
Did you have your little lunchbox?
All right, so we're back for episode two. We got some weeks under our belt now, so I just finished my second week of physical therapy school. We got Brad back again, of course. Last week we talked about networking and building connections with classmates. I did start talking to some more people, took the advice. So today we're just going to kind of talk about what the last 2 weeks have looked like at first, and then get Brad's clinical experience and knowledge to try to start applying some of the knowledge I'm learning and translate it over to what it looks like in the clinic.
That sounds great. I know it's been, it feels like it's been forever since I saw you. Well, that's not true. I saw you working out the other day, but
Mhm.
we didn't really talk much.
Yeah.
He was pushing some heavy weight. But yeah, so how's it? You said a couple weeks in now. It feels like it's been longer than that, but a couple weeks in. How's it going?
It feels like I've been in school for like 6 months and it's only been 2 weeks, but it definitely like the week after orientation, we just went straight into it. So we had technically nine classes because I count the labs as its own class, but basically nine classes in the first week. So that was a lot of information. Felt overwhelmed for sure. This week, same thing, just rolling through the classes, getting to do some hands-on stuff, which has been fun because that's when I like feel like I'm actually going to be a physical therapist versus like sitting in the classroom and learning all the information. But next week we have 3 exams and then 2 practicals. So we're definitely studying up. So it'll be exciting. I guess we'll determine how I do on the test if it's exciting or not. But to see how my study habits have been, kind of the microdosing we talked about last time, seeing if that helps for the exam. And then, of course, if I don't do good, start changing my study habits to try to do good on the next one.
Right. So does it feel like grad school or does it kind of feel like regular school?
It definitely feels like grad school, to say the least, even with, because I did my master's online and that like counts as grad school, but like compared to my master's, it is like, I would say at least 5 times harder than what I did for my master's. Just with because in my master's, I was taking like 3 classes at a time. So I've tripled my classes and it's all in person. So I actually have to go to class and not do it whenever I want.
That's good. I mean, it should be hard. I know when I was doing it a long, long time ago, that first semester to me kind of almost felt like just regular school because it's a lot
Mhm.
of like laying the groundwork classes, which we can talk about what all you're learning. I'm anxious to hear all the cool stuff that you're learning. But laying the groundwork classes, it's like, man, this feels kind of like regular school. I thought I was in PT school. Like you said, I'm ready to get my
Mhm.
hands on people. I'm ready to do stuff, which y'all did do the massage, right? You talked about that last time. How was that? How was getting your shirt off and rubbing on each other? How'd that go?
The massage was fun. We actually did that on the first week. So I think it may have been the second day of like actual PT school classes that we did massages. And of course it was upper back, so got real comfortable real fast. Luckily someone I kind of talked to in orientation week was there, so we just both looked at each other and we're like, okay, we're gonna massage each other. So we didn't get stuck with someone random. But it was fun to like do hands-on stuff, like I said earlier, because that makes you feel like the closest thing to when you actually work in the clinic of what you'll do. In that class, we did massage, and then we did get into trigger points too, which was fun because massage, the kind of idea behind the massage was to get used to like touching patients and like just the ethics, I guess, of like asking to touch them, making sure they're okay, explaining why you're doing it, um, and then kind of get into the actual trigger points and start doing some manual therapy. So that was fun too. I did have a lot of trigger points in my upper back. So, I mean, it's a fun class to get a massage. I would massage for 15 minutes. He would massage for 15 minutes. And we just kept going back and forth. So I got a massage while I'm learning. So that's hard to beat too.
You get the knots out. Do you feel better?
So we did the calf. My left ankle has no dorsiflexion at all. And my left, we only did one calf though, so my left calf felt amazing. The right calf, I definitely noticed the difference of not having a massage on it.
Yeah, it seems like that's always the pattern is to always treat one side. That way you can kind of compare. And so then you feel like you're kind of walking in circles because it's like, man, that one side's really loose. Feels great. Well, what were they talking about? You said getting used to touching a patient because that is a big thing. Sometimes we take it for granted. I know, like my background, I came from more sports and sports medicine, where it's kind of like, when you're with an athletic team, people are walking around in their underwear all the time, and like like it really wasn't that big of a deal, but it is kind of a big deal, especially in the clinic with protecting their modesty. Again, if you're with an athletic team, they have no modesty. They don't care
Mhm.
about anything. But in a real world clinic, yeah, we need to protect their modesty, number one, but then make them feel safe and secure when we're touching them and confident in our skills. What all did they address that at all? Kind of give me a rundown. What did they say about that kind of stuff?
Yeah, so we definitely talked about draping and how to make the patient feel as comfortable as possible. And then even just like, because we have another class that's going on too, which is physical evaluation procedures. So a lot of that has been like talking to the patient, learning how to talk to the patient, get information that you'll need eventually when we learn about interventions and how to treat. So really just talking to the patient. Personally, I like to talk even if it like we don't have to go straight to physical therapy where it's like I may if you tell me like you got hurt skiing, I may start asking you questions about skiing to build like personal rapport rather than just making it like an interview where I'm interrogating you for 30 minutes to see what's wrong with you. I think that helps get the person to kind of calm down, and then just learning how to talk to people, and then in each position, like if they're supine, this is how we're going to drape for the upper back. If they're prone, we'll drape this for the hamstring or calf, and just learning every position, and then also like pillow position, how to make sure they're comfortable so you don't have them like hanging off the table where their low back's excessively rounding. So we did talk about a lot of that stuff and just trying to make the patient feel as comfortable as possible. And then also us as the student physical therapists to feel comfortable actually putting our hands on people and finding ways to like, instead of just saying like to it, it's kind of weird how to word it. We're like learning how to word it without it like sounding bad, where it's like, hey, take your top off. And then it's like, okay, that's probably not the best way to word it. But it is good because it's like a mistake free environment. So the person I'm with, he's also learning, I'm learning. So it's like a very positive environment to make mistakes.
So did you get a chance to work on the discovery-based questions? It sounds like that's a perfect class to be those three discovery-based questions, even if it is about skiing.
Huh?
That goes a long way in reality. Is kind of it feels sometimes like a waste of time. You're like, I just got to get into the exam, but man, like that little deviation of talking about skiing, talking if they say something about a dog or whatever, that what is that? A 2 minute deviation, and like you're saying, man, it really goes a long way to making them feel comfortable. And of course, that's always going to help you because if they're not comfortable, then you go to palpate and actually do some tests, nothing's going to come back. It really messes up the physical exam if they're not relaxed.
Yeah. I think too something that I missed was like the actual massage method. So we'll start with something called like a light effleurage, which is just like we're not even really applying much pressure. It's really just like a light. I'm just basically rubbing over the tissue like very light with my full hand and using like that before I just start like jamming into a trigger point where just help the patient get used to the touch and then also like apply the free up and just make sure everyone's comfortable before I just start going right in. So we talked about like the methods of going from like a light effleurage to a deep effleurage, starting to try to lift the skin, then trigger points, and then working our way back out. So it's like a nice gradual increase versus just going straight in and making anyone feel uncomfortable.
Yeah, unless they're annoying, and then you just
Yeah.
like go straight in and like grip and rip. Is
Uh,
that's what they teach in school, 100%. Yeah, you're absolutely right, and it's pretty interesting when you're in the classroom right now. Obviously, you're talking about massage, but then we shift over into the clinic. We really are using those to. I don't really think of massage from a massage standpoint. It's more of like a sensory processing standpoint. And obviously, if we're seeing people, they're probably hurt. So they like movement doesn't feel good for them in general. They're just not going to feel good. So you're not coming to see me if you're like, hey, I feel great, and just want to talk about skiing. They're not going to do that. So usually they're the sensory input that they're receiving, which obviously goes through the skin, the fascia, the muscle, and all that. But that sensory input is really on kind of like heightened alert. It's a lot. So I mean, I've seen patients where just simply their shirt touching them just really hurts and bothers them. And so they're in this holding pattern. It's like, what's going on with this holding pattern? It's like, man, when my shirt rubs on my collarbone right there, it just feels like somebody's raking across me. And so, like you're saying, using the simple techniques of like effleurage or some skin rolling, that really light touch really does a good job of desensitizing that localized sensory nerve. And then, of course, they get a systemic effect with that too, because they're going to feel more confident. And then obviously, if they feel better, they're going to relax and all that. And so, as we get into the clinic, like we don't really use massage. That's not really like a language or a technique that we use. We'll classify it as myofascial release. You get build better if you do that, but that's where it starts. You know, that light stuff moving into deep. And of course, there's different mechanoreceptors that respond to different pressures, going from the superficial skin and then working deep. And sometimes, yes, we're attacking the trigger point itself, but a lot of times, just that deep pressure, again, is almost more from a sensory integration standpoint and getting that the sensory nerves and that fascia associated with it to just kind of, it's almost like, can we just take a breath a little bit here? And that's just a really good way, easy way to get in, kind of knock the edge off of the patient's symptoms, build a lot of confidence, build a lot of rapport because you're really close. So it's like, hey, you're like in my face a little bit. And so it is a really good opportunity to, like you're saying, build that good rapport that you like to do.
Yeah, and then so that was one of our classes. So we did of course we have 9, so there's a lot of more classes, but
That's a lot.
yeah. It's really 8, but I count the NeuroLab has a test, so I count it as its own class. But we're doing a neurobiology, which is fun. And then the one I've enjoyed that I didn't think I would enjoy that much was pathology. So the first lecture was a lot, or both this exam will be a lot about the healing process and then like certain diseases. But I really got intrigued with the healing process because I could see how that would, of course, apply in the clinic, like knowing that this person's in this phase, so maybe we should do this type of loading or intervention, even though we haven't talked about interventions yet. But I feel like knowing the stages of inflammation could help me make decisions based on the timeline when I'm actually working as a physical therapist. So that's been really fun to learn.
Okay, I'm gonna put you on the spot a little bit. Quiz time, just to see, because I'm sure it's all the same, but they do change the language a little bit over the years. So I got to put you on the spot. The healing phases, and you don't have to go into major details. Most of the people watching are in physical therapy school or physical therapists, so we kind of know what's up. But just so we're on the same page here, give me like an elevator spiel. What are the healing phases? This will get you ready for your test and everything.
I know we're going to see how the studying's been paying off here in a second. So some teachers, we've had 2 people teach it. Both teachers said that the first 2 phases, so hemostasis and inflammation, could be paired together. But just for simplicity, it makes more sense in my brain too if I split them apart. So I'm going to split them apart. So the first thing that happens when a tissue is damaged, we have the hemostasis phase, which is going to be the acute phase. Mainly, the main goal of that is to form the blood clot to try to stop the bleeding that goes on from damaged blood vessels. After that, within the first couple hours, inflammation is going to start setting in, which isn't bad. I've learned that inflammation is not bad. So this is going to be mainly cleaning up the debris, and then some of the protein molecules and other, I don't know the fancy term for it, but cells and stuff are going to start evaluating the
That's good.
damage. Yeah. Evaluating the damage and kind of seeing what plans they need or what steps they need to take to try to start healing the tissue. And then the third one would be proliferation, which is going to be basically when the vascular network starts growing back. And then the last would be the maturation phase, which is going to be the scar starts forming and then gets reduced and then remodeled.
What about time on that? Do you remember they talked specifically about that? Because there is obviously a window of time. It's not just a set. It takes 3.5 days or whatever. Give us a ballpark. What are the times for those phases?
Yeah, so let's see if I get this right too. Stasis.
Got him.
Oh yeah, put me on the spot. Stasis is gonna be I think it's gonna end around. Oh man, if my professors are watching this too, they may be so disappointed. I know
Look, man, get your phone out and cheat.
Yeah.
Get off screening.
So hemostasis is going to be the first couple hours. Inflammation, I want to say, is 3 to 5 days. So not a set day. It's around 3 to 5 days for inflammation to get out. Because if it lasts more than 5 days, we want to start being worried about chronic inflammation. The proliferation phase should be about 5 to 21 days. And then maturation is 3 weeks. And even depending on the injury, could last years.
All right, that's pretty close to what they taught us back in the day. I think the times have actually shortened up since I went through school. But yeah, that was good. Good job, Jake. You should be
Not too
proud of
bad.
yourself, my man. Yeah, good. Good job. Yeah, The healing phases are important. That was one of those situations when I was coming through athletic training. That was kind of the first thing we started with as well. And it was like, I mean, it was a really big deal. I mean, they were like, oh, you got to draw this post. They wanted us to like draw a poster and do all this stuff. It was like, why are we spending this much time on it? I'm ready to get to like the rehab intervention side of things. And so I just didn't understand. So I kind of did it just to do it. But then, oh, we moved past it. Great. And then I come to PT school and it's kind of the same thing. I'm like, daggum. All right. So maybe this thing is a little bit important. I still didn't pay that much attention to it because it's like, oh, that's all wound stuff. That's more like doctors. Like, well, I'll keep it on the back burner, but we're going to keep rocking and rolling. And then, of course, as I got into practice, it's probably every single day that I walk a patient through what you just described to me. Now I don't go through all all the hemostasis and all that. Like that's too big words. Big words are hard, so I'm not going to use big words unless I absolutely have to. But generally, kind of breaking it into those three phases, which the language we used was the inflammatory phase, fibroblastic repair phase, and then the maturation phase. So I still use those. They mean the same thing. And as far as when you're talking to a patient, they've never heard those words before. So they're just like, okay, he's using big words. It sounds cool. He must know what he's talking about. So that doesn't really matter that much. But it really does help give us a structure when we're discussing something with the patient, because they'll come in and that's the first thing they're concerned with is, when can I get back to what I'm doing? You know, I mean, a great example right now, we got football seasons kicking off right now. I've probably seen 3 or 4 kids this week with just these little injuries. These little, oh, tweaked my ankle, I tweaked my hip or whatever. It'd be a little hip flexor. I saw a hip flexor strain. I saw that somebody rolled their ankle. And again, structurally they're fine. You do all the ligamentous tests, all that stuff. And it's like, yeah, you're good, but it's still an injury, you know, so it's still got to go through the healing process. And that's what I have to tell them. It's like, look, man, we're talking about the first week of this inflammatory process. You know, I usually just break it down in a week because it's easier to remember. So, hey, for the first week, we're really just protective mode, let the body process what happened to it, clean the mess up, just like you said, and then get prepared to actually heal. And so, like you're talking about, it's really important to know those phases because the kids, the patients, they're wanting to get back to it. So we got to be really careful how we load this thing. If you're in the inflammatory response phase, and you jump back and we're loading it super heavy, or maybe it's not heavy, maybe it's just like a dynamically, just a load that maybe is kind of complex, then we're just going to stay in the inflammatory phase. And that's what happens, especially with athletes. We see that a lot. They just don't have the downtime to really rest and get through that inflammatory cycle. And then next thing you know, it's like, well, as soon as I start feeling better, I just get back to it. It's like, well, you feel better after about 2 days, really 2 or 3 days, and then they start feeling better. And so they'll jump back in it. Or I see this with, I mean, normal patients too, you know, non-athlete. Like, man, as soon as I felt better, I just went back to work and started, you know, lifting that 50-pound box and doing it. It's like, now we're in chronic inflammation and our body's really having a hard time moving forward. So it does. It's very important to know that stuff. You mentioned loading. How much did you get into that? I know that's probably more of like a therapeutic intervention class. How much did y'all address that while talking about this healing stuff?
So we did talk about like not like specific interventions like this is the exact exercise you would do for a sprained ankle, but we talked about guidelines. So inflammation phase, we talked about no direct loading to the tissue unless it's like a very submaximal isometric that is pain-free. Proliferation phase, the biggest thing is we could start beginning to load the tissue, but we want to drive volume rather than intensity. I hope I'm saying this right too. But
It sounds good.
yeah. I could be like totally not saying what they taught me. I haven't reviewed it in a couple of days.
Say it with confidence,
Yeah.
and then that's it. Fake it till you make it, my man.
And then the last one, the remodeling, we're going to start doing like progressive exercise. And then the biggest thing is just return to the activities that they want to return to. So if it's a football player, we're going to start doing dynamic control and progressive overload the tissue. And then one of them is pain should guide the intensity, but I'm thinking through and I can't remember which one it is. I'm assuming it'd be all of them. Pain would guide intensity, but
Yeah, it would. Pain is definitely an inflammatory response thing. You know, we're going to be much more concerned with that. We got to be a little bit careful with it though, because pain can be almost like a false positive. So Pain is one of those really weird things that is a very high priority for our patients. Because if they weren't in pain, they're not coming in to see us. You see people walking around limping all the time. It's like, why are you moving like that? They move terribly. They're like, well, I don't hurt, so everything's fine. Clearly, everything's not fine. But the standard for a patient usually is pain. And so we have to be very conscious of that. But at the same time, especially in the inflammatory phase, I mean, a lot of times everything's painful. And sometimes they perceive it as painful, especially if you're running into some chronic issues. A low back is obviously the easiest one. You have a chronic low back patient that really is, even though it's been going on for months or even a year, I mean, they're really reacting more like they're in the inflammatory phase. Now, if we were to do like a blood draw and look at their hormones and stuff, it's like, hormonally, you're probably not in the inflammatory phase, but your pain response and things like that are very much following the inflammatory pattern. And so, yeah, you got to be like really conscientious about that. And then sometimes loading, especially in a chronic patient, if we can get that progressive overload and work it up to where it's kind of heavy, then what that does for us is it kind of allows that nervous system, that sensory, input system to reorganize into a different priority. So if we're not technically in the inflammatory phase and that tissue is not just completely damaged right now, we're starting to actually get new collagen fibers to lay down, or it's chronic, it's like, hey, structurally you're good, you just got this weird pain response. Sometimes that loading, especially in isometrics are really, really good for somebody in pain, to where like, man, we're pushing pretty heavy. Most of the time, if you look in the clinic and we're doing isometrics or eccentrics, we're probably not doing them heavy enough. We always kind of default, like you said, to more volume, more reps in volume rather than more weight in volume. But like a heavy isometric, like a heavy load, especially in a safe range of motion, really kind of helps that nervous system reorganize and prioritize the activity rather than prioritizing the pain that they're in. It's kind of interesting. I'm sure a smarter person can explain the neurodynamics of all that stuff, but you kind of got to be a little bit careful. You got to give it time, like you're saying, to get through that inflammatory phase and start laying down some new collagen, get that to anchor in before we can really start getting loaded.
Yeah, that was one of the things I brushed over is like, especially during the inflammatory phase, like just because you have an injury in one place doesn't mean that your whole body is injured. So like doing light isometrics or controlled movements just to make sure that the nerve can still talk to the muscle and just restoring as much function as possible in the surrounding areas. That was definitely something I took away just because I feel like as a CSCS, I do see like shadow or maybe like just hearing about physical therapy is that a lot of the patients are underloaded just because some physical therapists may not have as heavy as an exercise background. So I guess finding the line between like underloading, of course, knowing the population, I'm not going to load a college football athlete the same way as I would like 92-year-old Miss Betty. But like, I don't think necessarily like when Miss Betty's in the remodeling phase, if she has built up to like a sled push, that Miss Betty can't be on the sled, just like a college football player. So I think finding like the line of like, I don't want to be an underloading physical therapist, but I also don't want to be like the CSCS meathead that's like just trying to kill their patients either. So how do you kind of like guide like the intensity level as you're going through the healing phases?
That's a really good question. Some of that is just a little bit of experience. We can't combat that. I think sometimes that's what happens. We come through PT school, we're expecting like an answer, and so you get these big parameters. Oh, it's going to go from 2 weeks to 6 weeks or whatever. You have these big things. And it's like, okay, I need to be more specific. And unfortunately, we just can't give it to you. You got to get that in experience a little bit more. But obviously, we talked about pain. That's one easy indicator. The other one is just really quality of motion. That's the biggest thing. That can be a little bit challenging, especially with some of our older patients that they're going to have years of this kind of weird compensation pattern. So it's like, I really want to load you, but I got to have a nice vertical spine. Like, yeah, if the kid's 14 years old, we're going to really worry about them driving those collarbones up, get that T-spine nice and locked in, good, stable, stacked spine. Well, if they're 82, they're probably not going to be able to get stacked in the traditional sense. And so then it's just kind of figuring out, can they control the load that we're putting on them? And so if we use that, especially with the older population, if we use that, then we start to really kind of establish an easy progressive overload principle. that as soon as they quote unquote lose control, and so say that, hey, if I put you on a load, even though she may be a little bit kyphotic, if I load you with the med ball hold right in front, if she stays in that kyphotic posture and nothing changes, nothing flexes more or anything, then she's good. She's got good control of it. I mean, we see that with like strongman. You know, you see the strongman pick up the Atlas ball, your back's got to be straight. Their back's not straight. They're rounded as all get out. But the thing is, they stay in that position as they go through it. And so they're controlling the motion. And so that's really how we determine how do we progress. The other problem that you're going to run into is the vast majority of people don't lift weights. They don't really expose themselves to that stimulus. So it's a little bit of a culture shock. It's a little bit weird. So if you give them even like a 2-pound dumbbell and ask them to do just a normal shoulder press, it's very strange for them, especially the older population. That population kind of doesn't really work out. Especially when I was really young, there was, those guys are kind of starting to die off a little bit, but like they were really, especially the women were very proper. Like, oh, women don't do that. We're not going to get sweaty and do that. And so they really are kind of all over the place. So the biggest thing is how do we progress them, making sure they have the neuromotor control. That's the language I like to use when I'm doing my documentation. And that again is a billing thing. Like we can actually bill that. So it's not just strengthening, but there's actually neuromotor control. And as you know, Jake, from the CSCS, our first big chunk of adaptation happens neurologically. And so kind of a tangent, are we really strengthening people or are we doing more neuromotor control?
Mhm.
Probably doing more neuromotor control if we really stop and think about it. But the bottom line is we have to have some kind of stimulus that's creating an adaptation, and then that stimulus has to progress. That's all we're doing. So you can claim it as strengthening if you want to, or neuromotor control, but give them a stimulus. They're not going to be good at controlling that stimulus. That's the point. We're going to push them out of that comfort zone, whether it be a load or just a balance or whatever, and then give them time, a little bit of instruction if we need to get them to control it. And then once they got it under control, okay, well, now we're going to push them just a little bit outside of that. And again, this is where your experience is going to come in, is how much wiggle room do you give them? Because some people, you'll be like, man, they're really rounded or whatever, and it's fine. Other people have a very small window. So it's a little bit of just, once y'all get in the clinic and experience it, you'll gain that knowledge. But the bottom line is, I think control is the easiest way. A little bit of pain, but control is the easiest way to determine, hey, are we ready to progress or not?
Yeah, I think especially too, just like imagining if I was a clinician right now, like in a clinic, as a CSCS, I'm all typically with people that are generally healthy. So I think like there'd be a lot of fear of like I as the PT, like I do not want this person to get hurt again or make it worse. Like that'd be terrifying if like first year I have like a ankle sprain high school football player and I end up making the ankle sprain even worse. So I guess like would you lean on the side of caution as a new grad? Or
Yes, the easy answer would be yes. But at the same time, you gotta do stuff. You're gonna make mistakes. Everybody does. Every therapist out there has hurt a patient. It's just part of it. If we're going to try to create a progressive overload where that system can actually adapt and grow, that's what our bodies need. So we're kind of, at an impasse here. We got our backs against the wall a little bit. Like we have to push you a little bit. We got to push you forward. And so doing that, obviously, we're going to make some mistakes. I mean, maybe it wasn't even a mistake. Maybe you're just unlucky. That happens too. Sometimes you're unlucky. The dude caught his toe on the carpet and rolls his ankle again. It's like that had nothing to do with the exercise you did. That's happened to me countless times. It's like, dude, pick your feet up when you move. That's going to happen. So just kind of be prepared for that. But definitely, like you're talking about, kind of fear from maybe a clinical standpoint, like, hey, a clinician standpoint, that, hey, I'm a little bit afraid to load them. The patient has a ton of fear associated with them. And that's the thing that we really, really got to be careful with. It. Our progressive overload is a physical progressive overload, but it's also this kind of mental overload that I've never done this before. I mean, I can't tell you how many times I've heard that. I mean, it's multiple times a day that we're doing something and that's the response. I'll show them, talk them through it. Look, this is what we're going to do. It's going to help that muscle grow and you're going to be nice and strong to be able to do stuff. And like, oh, I've never done anything like that before. That's their way of saying, I'm not too sure about this. And so then it's okay, do I need to scale back then? Sometimes that determines how fast you can progress. I've had that happen 1,000 times before. To do something, especially with compound multi-joint movements, it gets very complicated. It's very scary looking. Pushing a sled sometimes is scary. I kind of got in trouble years ago when I first started at the clinic I was at, where I had my older patients pushing heavy sleds. So they're 80, 85, even 90 years old. And I got them out there and we're pushing sled at body weight or higher. And I got a lot of pushback. It's like, dude, what are you doing? Like, this is crazy. And it's like, well, if you would rewind the clock and see, I've been with them for 8 weeks and we've progressively exposed them to this concept of loading and pushing the sled and both physically and mentally they were prepared for it and they loved it. It's so funny to see like a 90-year-old woman and she's 90 years old, 105 pounds soaking wet. She's pushing 100-pound, 135-pound sled and she's like, oh, I feel like I'm so strong. They get a kick out of it and they're having so much fun. And of course the outcomes are going to improve when they start having fun. They get all happy and stuff. Body heals better when they're happy. But yeah, you gotta, it's a progressive overload in both physical and mental for the patient, but even us too. You got to kind of sometimes talk yourself off the cliff. Oh, I don't know, did I make a mistake or whatever it may be.
Yeah, I never honestly. I know there's of course mental aspects to like strength and conditioning stuff, but I always think about like my first thought of that was like my fear of getting someone hurt. So thinking of like the patient's mental side too was something that I'll take away for sure. I think maybe for the last part here, maybe we like walk through a fake scenario and kind of just like quickly talk about like what each phase would look like. So now that you gave me a quiz earlier, I'm gonna put you on the spot.
Oh no.
You
All right,
gotta, let's say we
what do you want to
got,
talk about?
let's go a high school football athlete, and let's just make it easy. We'll say ankle sprain, since we already talked about some ankle sprains. So he comes in, let's say it happened yesterday. He played yesterday, sprained his ankle, and he's coming in to see you. So kind of what does that first like hemostasis or inflammation phase kind of look like in the clinic?
Well, usually they're going to have like a goose egg. If you're that, especially if it's like a grade one, then we get into grades, right? Grade one, grade two, grade three, and that just refers to the amount of tissue damage that's there. Obviously, grade three is like it's the big boy, and we got big time loss of playing time. But generally speaking, it's probably going to be somewhere between like a one and a two. If I were to just put my money on something, generally I see it's going to be, oh, that's a high grade one, maybe a low grade two ankle sprain. All right. So what that means is, yes, there's been some fibers are torn, and so they're swollen, they're scared, they're mad. Usually the athlete is super mad because he's thinking he's not going to get to play. Usually mom's sitting there, so mom's always worried because, oh, my baby got hurt. And so there is a bunch of that kind of fear. There's a lot of tension in the room. Let's just say that, you know, because it's Tuesday and they got to play on Friday. So obviously the first thing you're going to see, there's a lot of swelling. Right. Well, we want to control that. Like you said before, swelling and inflammation is not a bad thing, but we don't want it to go crazy. The ankle is a very interesting joint because it's way down low. Gravity's working against us, so it is very easy for that swelling to linger around in that joint. It's hard for the lymphatic systems to start pumping that stuff out. And so our first thing, we're thinking inflammatory response phase. We got to try to control that swelling, get the old, nasty, stagnant swelling. It's kind of like an oil change. That's the way I always think about it, the way I describe it to patients. It's like, hey, you got old oil down in there. That's what that swelling and stuff is. And it's done its job. Now we need to get that out of the way so we can get some new oil down there and it will clean up the area some more. And if we can keep turning that, so we just need to change that oil as much as we can, and it helps to really clean that up and allows us to push forward to the inflammatory process as fast as possible. Right? So that's elevation and compression. Ice, whatever you want to do. I'm not an ice guy. The research doesn't really support it. It does make you feel better. So if you're talking about like a pain control aspect and you want to put ice on it, then by all means do that. I don't necessarily think I would put heat on it. It's going to pour a bunch of blood down into the area. Generally speaking, I say whatever you want to do, but we definitely need to have compression and elevation. So whether that's an ACE wrap, depends on the type of clinic you're in. Sometimes it's simply an ACE wrap. Sometimes like a Normatec compression boot, Game Ready, something like that. There's all sorts of cool technologies out there. So we got to get them elevating that thing above the level of their heart with some compression on there. And knowing that, hey, we're in protective mode. So chances of you playing on a Friday night, probably not super high. It kind of depends, not getting too much in the weeds of it, but it kind of depends a little bit about where they are within their season. I know that necessarily shouldn't matter, but at the same time, hey, if you only got like one more game left, and this is the last time you're ever going to get to play football in your life, I'm probably going to tape that ankle up and make basically a cast and say, dude, if you can handle the pain, then deal with it and we'll rehab you after. If it's at the beginning of the season, like I saw a kid actually just yesterday, it was a back issue, but kind of a similar thing. He's 14. I'm like, dude, you got a lot of football left. Like, let's not be stupid here and cause a serious injury by pushing into playing time. So we go into protective mode, so you're not going to be doing a lot. Maybe walk around, that kind of thing. Hey, when you go to practice, hey, keep it moving, that kind of stuff. We'll introduce active range of motion, all very, very light, all about keeping that fluid moving through that ankle, get that inflammation out. All right, so that's, again, we go back to our time frame. That's going to be the first week. It kind of depends on a lot of other variables with insurance and things like that. But a lot of times I'll see those patients daily, especially if it's an athlete. I work in a little bit different environment where I'm a little bit more cash based, so it frees me up to do things a little bit differently than the standard PT. And we also work with teams that have athletic trainers, so I coordinate with them a lot. But anyway, I
So
digress. Yeah, I'm sorry,
in
I'm
the
rambling. Go ahead.
in the inflammation phase, are you doing like body? How are you like restoring? Are you having to move at all? I guess you could say like the injured area, like some if it's a ankle sprain, like maybe some ankle pumps, like unloaded controlled movements and stuff. Kind of what does that look like?
Yeah. So again, I personally tend to approach things from a neurological perspective, so more of a sensory integration perspective, which when I do that, it does kind of just naturally flow in line with the inflammatory and repair cycles and maturation cycles. And so again, it's an acute injury. Yes, we do have tissue damage, so there's collagen damage there. That's what an ankle sprain is. But the sensory nerves and mechanoreceptors associated with that tissue they're lit up like Christmas trees. They're like, this is some major trauma just happened to me. I gotta really protect this. And so until we get those things to calm down, we're not going to be able to restore natural movement. And so yes, I may be doing ankle pumps to promote, lymphatic drainage, a little bit of active range of motion. But the other thing that I'm doing is I'm recalibrating those sensory nerves and those mechanoreceptors back to normal. Like, okay, the trauma happened. It was not fun. I'm sorry, but we need to start getting over it a little bit, you know. And so what that looks like is exactly what you said. We're doing ankle pumps. We're doing write your ABCs. We're doing manual techniques. So I know that's down the road. You haven't really gotten into that stuff, but like Mulligan ankle mobilizations are really, really good for acute ankle sprains. Even just putting your hands on them, kind of going back to the massage thing we talked about before, putting your hands on them and applying like some manual compression with some active movement, they just respond really, really well to that. It just makes them feel safe and comfortable. It calms those mechanoreceptors down. And so doing things like that, just manually touching them, making sure the acute biomechanics are there. But to answer your question, it'd be yes, ankle pumps are great. Write your ABCs. I do want to try to get some loading, so that's where weight shifts are going to happen. So multi-directional weight shifts forward, so we're getting all planes of motion. That's the other thing. Ankle, we got three planes of motion. We always have to remember our body operates in three planes of motion. What happens a lot of times is we get stuck in the sagittal plane because it's just the easiest one to work in, but there's sagittal frontal and transverse planes. And so from an acute standpoint, I still want to start trying to stimulate those sensory nerves within those three planes of motion so we can start getting back to baseline as fast as possible.
Yeah, that makes sense for sure, and helps me like piece together kind of what's happening in the inflammation phase and then what that would look like clinically. So let's say edema is starting to come down or swelling, and then we're starting to enter the proliferation phase. So what kind of like progressions would you have as you start to see like we call them the cardinal red signs of like heat, warm, swelling, and pain. So as those start to like come down a little bit or like technically enter the proliferation phase, kind of what are your next steps there?
Well, the whole idea with that phase of healing is that we're laying down new collagen. That's what's happened, right? So the ligament got damaged. We tore a certain percentage of the collagen fibers there. And so we have to put some kind of stimulus into that tissue so that the body understands this is the direction of force that I have to control. So that's how it determines how those collagen fibers lay down. If we don't do anything, we don't stimulate it appropriately, it just kind of gets this spit wad. And that's what those are those patients that, oh, I didn't rehab well. They have terrible ankle range of motion. Maybe that's what's wrong with your ankle, that you you didn't rehab it right. But we want to stimulate in a appropriate way in the proper lines of force so those collagen fibers start laying down. Now, the easiest way, this is where you see your traditional TheraBands. So if you go into any PT clinic, you're going to see at least one person with a TheraBand holding it there, and they're doing dorsiflexion, inversion, eversion, plantar flexion. They're doing that. That's great. That's a great home exercise program. Do I waste much time with that in the clinic? Don't. I introduce it, and then I'll check in on them and make sure they're doing it every once in a while. But that's a really good home exercise program. Let's not waste our skill on something like that. But we're going to start really loading, looking at the foot and make sure the foot provides enough stiffness. Because again, we got to remember what the ankle in particular, since this is the example we're talking about. The ankle, we need to transmit the force that we're creating with the bigger muscles, the glutes, the hammies, the quads. We need to transfer that energy through the ankle, through the foot, and into the ground. So we need to really go ahead and start looking at what the foot is doing. Can the foot create that stiffness? Things like the Windlass effect, which I think y'all will learn down the road. I know you and me have talked about it before, but like things like a Windlass effect, can we create stiffness in the foot? And so while we're stimulating the ankle and it has kind of a low tolerance, we can start working on foot, calf, hamstring, that kind of stuff. Obviously, gait cycle is really big at this point. The best stimulation we could do for an ankle is to walk correctly. So that's where like underwater treadmill, we have one of those. We do that kind of stuff. Alter-G, that kind of stuff. Even using, I've been places where I've had to use like a jump band and like strap them to the pull-up bar right there and pull a treadmill underneath them so they're kind of hanging and so that they can kind of walk more naturally. So we're going to start there, and then you're just progressive overload. All right, we need to increase the weight bearing stuff. Introducing squats. I introduced squats pretty early with that. Lunges, single leg press, lateral squats, things like that are the more natural loading. Again, pain is a big indicator, but control is the number one thing that we talked about before.
Yeah, that makes sense, especially too in class. We've talked about the collagen formation. So basically, whatever stress you apply, that's the way that the collagen will line up. So that does make sense. And then I guess lastly would be the remodeling phase. Is that just starting to try to get them as back to normal as possible and prepare them for the activities that they are trying to get back to?
Yeah, pretty much. An athlete is different. All patients have to deal with it, but the athlete is really different. Everything that they do generally runs at high speeds. And so that's one of the downfalls of being in a physical therapy clinic is most of the time we don't have the space to stress them at the high speeds that they're going to be dealing with as soon as they go back to the sport. So if we're thinking like progressive overload, we talked isometrics. Isometrics, there's like no speed. There's nothing happening. And so it's just a load. That's where we start. And so if we start where there's no speed, then it's kind of a logical conclusion that, okay, I need to kind of end with high speed stuff. And this could be true with our regular patients as well, because it's just normal walking, going up and down stairs, things like that. There's a speed component with that. And so what we're trying to do through that maturation, we have enough collagen laid down now where we feel a little bit safer, where I can stress you a little bit. This is where you should start feeling sore after a workout. It's kind of, hey, 24 hours of soreness, and it should be done. If it goes beyond that, then it's like, oh, maybe I overstressed it a little bit. So that's where we have to really communicate with the patient and get them to understand what level of pain, what level of soreness is okay. Because you have, especially some football players who just want to get back at play, they're rolling at 8 out of 10. And they're like, I'm fine. It's like, dude, you're not. Like, I can see you grimacing. You look like you're about to throw up. You're in so much pain. Like, no, it's fine. It's fine. This is football. I can do it. And just a lot of communication about what is soreness versus pain and things like that. But again, we're working through, hey, isometrics, which are really, really good. And then we get into fun stuff where it's like, hey, at high speeds, there is one part of your body that's working isometrically while another part of your body is working at a very high speed. And so that's, again, neuromotor control, systemic integration is the fancy word that I use for that kind of stuff. And so that's when it gets really, really fun. That's when you're thinking, I'm a PT now. I'm doing PT stuff. That's fun. But of course, high school athlete hanging on your shoulders, we got to get them back. And so we're going to speed that process up probably faster than what we want to do. And so we're always kind of balancing that act right there of, hey, we know that we still got 6 weeks before this tissue is really healed. We're at week 2, week 3, and maybe we're treating them like they're at week 6 because they are a dynamic athlete that has to get back. Again, we just got to be really, really careful. Can they really control this stuff? This is where you start seeing like your return to play testing becomes a huge asset for you, and understanding what that is. There's millions of tests out there, single leg hops, Y balance, things like that that'll really, really help guide your progression, and see if they're ready. Y balance is a very simple one, especially with an ankle. If they can't pass that Y balance, then they really don't demonstrate the neuromotor control, strength, balance, all that to even run, much less return to sport. So that's kind of like an example of a kind of a gateway special test or functional test for us as we're getting into that maturation and later phases of the rehab.
Cool. I feel like I just went through my first like rehab. I feel like I just rehabbed the ankle, but that is definitely helpful to like take what's in the classroom and then try to bridge the gap to the clinic. And I mean, most of the stuff you talked about was like what we're talking about in the classroom. So give you some
Perfect.
props too. I guess you know your stuff. But yeah, so next time we talk, I'll have my exams under my belt. So if I don't bring them up, just don't ask about them.
Oh man, that's fair.
Yeah, so cool. I think you got anything else to add before we end it?
No, I mean, it's a lot of information that we kind of went through, and I know you're drinking from a fire hose right now, but again, it sometimes feels like a silly thing that you're kind of having to study. It almost feels like, oh, they just had to put an extra class in there. But we definitely, from a clinical perspective, having a firm grasp on these healing times and what is actually happening within these healing phases, tremendously important, much more important than I realized when I was young. It took me a couple years to really, oh, okay, this is very, very important. And it's really going to help you if you kind of trust the process. We had to say that to our patients all the time. Hey, this is the way your body heals. You got to trust the process. Well, you have to say that to yourself as a clinician too, because you're like, I'm going to get them in here and I'm going to get them better. It's like, yeah, but God created us in a special way and we heal at a special time. And no matter how good you are as a clinician, we can't escape the time aspect. And so definitely just take it to heart, log it in. This is a very big thing that you need to make sure you're remembering. There's some other things that you can forget, but this is definitely not one of those things.
We'll next time talk about everything else that we learned and then either talk about the exams or just ignore them and see how those go. Cool.